Welcome to another episode of the Your Longevity Blueprint podcast. Today, my guests are Larry and Belinda Wurn, physical therapists who have spent 40 years developing and refining a unique hands-on therapy shown effective at replacing major surgeries for some serious health conditions. In 1984, surgery and massive doses of radiation therapy left Belinda with a frozen pelvis. Finding herself in debilitating pain, her abdominal and pelvic organs bound together by adhesions, her doctors predicted a lifetime of terrible pain. They said surgery would cause more adhesions, making her situation worse. Unwilling to accept their bleak prediction, the couple embarked on a multi-year quest for non-surgical cure. They began by taking dozens of advanced therapy courses in the US and Europe, hoping to return a quality of life to Belinda. Together, they began to create techniques to decrease adhesions manually with their hands. Combining techniques from respected instructors and inventing methods of their own, they spent decades developing and refining protocols to create a non-surgical, drug-free therapy shown safe and effective at decreasing adhesions naturally. After the therapy opened blocked fallopian tubes in dozens of women, they named their work Clear Passage Therapy. Numerous peer-reviewed studies from independent doctors and scientists show their therapy has reversed infertility from various causes in hundreds of women. It has decreased pain and returned function to men, women, and children. Besides opening totally blocked fallopian tubes, Clear Passage Therapy was shown to increase sexual function, decreased post-surgical adhesion pain, and clear life-threatening bowel obstructions, the second most common cause of emergency surgery in the U.S. Today, the couple authored several Okay, I misspoke. Let me repeat that. Together, the couple has authored several books about the therapy. Belinda wrote a 590-page therapist training manual the Wurns used to train physical therapists to use Clear Passage techniques and protocols. Today, patients from all over the world attend Clear Passage locations in the US and the UK. Wow, that's a lot. Great story. Welcome to the show, Larry and Belinda.
Thank you very much.
Thank you.
Nice to be here.
Your work at Clear Passage was truly a game changer in my own fertility journey. I mentioned Clear Passage in my new book, Your Fertility Blueprint. After multiple surgeries for infertility and dealing with SIBO, I had adhesions creating barriers I didn't fully understand. And so your technique, which was more thorough than anything I had ever experienced, became one of the key pieces that helped me finally conceive Michael. So
Wonderful.
what's remarkable is your track record. So better outcomes than surgery for blocked tubes, results comparable to IVF, but completely non-surgical. So let's dive into what adhesions are, how they affect fertility and overall health, and how innovative this therapy is and how it works. So again, welcome to the show.
Thank you.
Thank
Thank
you.
you. All right.
So
I'm sorry.
your
Well,
story is quite the story. So I want to open with that. I read a little bit about that in your bio, but how did you come to create this therapy? Walk us through that journey.
Oh boy.
Take us back, way back.
Go way back about 30 years. Back in, I think it was 1984, I developed cervical cancer. And by
Yeah.
the time they found it, it was stage 2B, which means it had spread from my cervix um, into the tissues supporting the uterus.
Sure.
So they were very aggressive with treating me with radiation therapy. I had to go uh, for 2.5 or 3 months of everyday radiation to my pelvic area.
Wow.
So, I got all kinds of symptoms from that. I mean,
Yeah.
bad diarrhea and extreme fatigue, but it killed the cancers, and I'm still here. But it basically destroyed my ovaries and threw me into menopause.
how about
Yeah,
when
yeah.
well, the other thing is, I mean, nowadays they'll do a little radiation for a few seconds at a time. They took
Oh
these
yeah.
tubes that looked like a cigar, what you hold a cigar in, stainless steel, filled them with irradiated material, surgically implanted them the full depth of Belinda's uterus, put her in a lead-lined room with this stuff inside of her,
Yeah.
everything unprotected. And then the nurses said, it's dangerous for us to be in this room. We'll bring you food, but we can't be in here for more than 5 minutes at a time because of the radiation inside of you. But we're going to keep you here for 3 days.
72 hours
And they
worth.
did that twice.
She got
So,
blasted. Absolutely
yeah,
blasted.
Yeah,
Yeah.
twice, 2 weeks apart.
yeah.
Yeah. So
Uh,
it's pretty brutal.
And since I've known her since she was 2 months old, we grew up together and loved each other and saw each other grow up all our lives as kids and then professionally. I loved her a lot. And I said, no, there's got to be an answer other than surgery for adhesions, as you know, Dr. Gray, are a huge problem in medicine. I mean, after cardiac surgery, they'll squeeze the heart, they'll constrict the heart. When they in cancer, adhesions will cover a tumor so that the chemo can't get to it. They block fallopian tubes, as you mentioned, are a major cause of female infertility and life-threatening bowel obstructions. So
So she was full of them and you wanted to find a solution, is what you're saying.
that's right.
Yes.
Right.
So can you explain to the listeners what adhesions are?
Adhesions are basically internal scar tissue that forms after someone has either surgery or trauma, like a bad car accident or a bad fall. These cells rush in to protect the damaged area, the traumatized area. And the thing about adhesions is they, as adhesions form, and if they're cut away surgically, more adhesions form. So it becomes a snowballing problem. So
I'm
the
ass
adhesions
I'm
can,
assuming that's what happens with, so I had stage 4 endometriosis. So when they go in there and, burn the lesions, they're essentially just creating more scar tissue. So it's this vicious cycle.
just
Yep,
cycle. Yeah,
That's
it
yep,
right.
is.
yep, yep.
Yes.
So I was going to ask what causes them, but you kind of already answered that. So, I mean, a lot of surgeries cause them. You're kind of saying trauma can cause them.
So, yeah.
Yeah.
So, the adhesions are basically like they glue things together. I mean, so they start sticking organs and tissues together that can start causing symptoms like pain and different kinds of organ dysfunctions. So, they're a real, they're a very big prevalent problem in
But,
many cases.
and I assume a lot of people don't know they have them. So how would someone know if they have adhesions?
Basically, anybody who's ever had tissue damage has adhesions. They are internal scars that form, and structurally, the way they form is tiny strands of collagen, very strong fibers. Same thing the tendons are made of. Start laying down on each other in a random pattern, and they form an internal scar that's now been measured at 18,000 pounds a square inch. So you
Pretty
could
strong.
lift an elephant with a square inch of it. So the way you know you have adhesion, and they don't show up on X-ray, MRI, or CT, if you have unexplained problems. I have this stitch here in my under my ribs, and I keep telling my doctor about it, and then he or she does these tests and says there's nothing there.
Yeah.
Suspected
Could
he.
Yeah,
could
and
be an adhesion.
they
What's
don't
the
show up on diagnostic tests because they're soft tissue.
So you as a physical therapist can manually just determine if they're there
Yeah.
or
I
okay.
mean, all the organs in the abdomen and pelvis should be able to slide and glide over and around each other as the organs function, but also as you move around doing all your daily activities. And when things get stuck together, people start having symptoms. And, that's when we would suspect adhesions.
And what's the pain connection? Is it just that the adhesions restrict mobility or what's the pain connection?
I have one that you can relate to because it has to do with endometriosis. Okay. And I'll get to the answer to that question. We were at a large NIH invited us to a conference of endometriosis experts from around the world.
Mhm.
And we were treating endometriosis and having really remarkable success with women that were saying, wow, my period came, I'm usually doubled up on the floor for 2 or 3 days. I didn't even know it was coming. And so I stood up. I stood up in this group of 400 physicians and said, "Is there a consensus in this group of where the pain comes from with endometriosis?" And there was total silence in the room. And Alice Domar from Harvard was a few rows in front of me, and she turned around. She said, "Larry, we just don't know." But I think we do because when you think about it, when endometrial tissues form anywhere in the body, adhesions generally form when that tissue, and it's kind of like Gulliver's Travels, if you remember Gulliver tied down by the Lilliputians, these little strands that form between the endo implant and the underlying surface. When it swells each month,
Yep.
that pulling, and that must be where the pain is coming from because all we were doing was decreasing adhesions, but we were getting
Yeah.
dramatic improvements in endometriosis. So it's because of
Yeah.
the very powerful bonds, you try to move and it pulls and I got pain.
Sure, sure. Very interesting. So how do doctors typically treat or remove the adhesions? And then obviously we want to hear how you're different, but what's the typical conventional approach to adhesion removal?
The typical approach is surgically removing them, cutting them out. And, that helps usually for a month or maybe a few months, but then adhesions form from that surgical procedure itself. So, again, it becomes a snowballing problem.
Sure.
The Journal of Laparoscopic Surgery just came out and said that 97% of surgeries cause new adhesions to form exactly in the place where the surgery was done. So no matter how brilliant, compassionate, and wonderful your physician, they can't help the fact that you're going to heal. And the way the body heals is lays down adhesions.
Sure, sure. Well, you just mentioned endometriosis, so let's go to infertility. So connect the dots not just with endometriosis, but how do adhesions cause infertility in women?
Well, the adhesions can block fallopian tubes, preventing the sperm from getting into the egg, preventing conception.
Hmm.
They they can cause severe period pain. Um,
They can
yes.
they can create adenomyosis. They can form within the uterus. When you think about it, every woman who has ever had intercourse has had a non-surgical, a non-sterile object inserted into them into an area that's designed to grow life. So bacteria
Yeah,
go in there.
yeah.
They go, wow, what a perfect environment to grow.
Nice and
And
warm.
they
Yeah.
grow, and adhesions can form on the on the uterine wall.
Vaginal
Oh, well,
walls.
they
Yeah.
can form on the
Which,
vaginal
yeah,
wall and cause pain.
which could explain why someone could have adhesions who hasn't had surgery. Yeah, yeah,
Exactly,
okay, okay.
exactly. And
And
from there, I'm sorry,
no, no, you go, you go.
on your question, from there they can go up into the uterus, form on the inner wall of the uterus to make a less hospitable surface for implantation. Okay, it's not lush anymore. Now it's got these curtains of internal scarring and can form in anywhere else. We think that the reason we have success with PCOS is because there seems to be this white substance that forms on the outer wall of the ovaries in PCOS, and doctors will drill into that ovary or cut a third of it
Got a
off to help
wedge.
free those eggs up. But I think when we're freeing those up, we have actually pretty good success. I think it's 54% pregnancy rate in women with PCOS. So,
So it sounds like you're saying really any part of the reproductive tract could be affected by adhesions, which can then impact infertility, and you can work on all of the above.
that's
I mean,
Yes.
the
right.
uterine has to be freely mobile, right? I mean, ideally. And so post
Really.
C-section, so I came to see you after my first C-section and other multiple surgeries, yeah. In an effort to, I thought I just got to explore what else could possibly be, hindering my ability to get pregnant. But my
Mhm.
uterus was pretty stinking fixed. Plus I had the history of, endometriosis. So just freeing up the uterus to be more mobile to receive the embryo, or yeah,
Yeah.
yeah.
So, yeah.
Explain further what I'm trying to say.
Yeah, well, the uterus needs to be able to expand as, once you have a fetus, implanted, the uterus needs to be able to expand and grow, but it also needs to be able to move again as you move and walk and, do all your daily activities. And if things get bound down, that can cause problems and can cause pain
Scary.
And
and,
and so
and can cause miscarriages too.
sure, sure. So explain the C-section, I guess, link here also, or limitation. So after one woman has had a C-section, she's going to have more scar tissue in there, right? So her uterus theoretically is going to be less mobile. So would you say every woman who's had a C-section needs this sort of therapy? I mean, post-surgery?
It would be good, just to give them the best chance of conceiving another pregnancy, having a
Yeah.
healthy, normal delivery.
Well, when you
Yeah.
think about it, a C-section is a major surgery. I mean, you're cutting through so many different tissues and then cutting into the uterus itself. All of that has to heal. So again, no
And
matter what,
stick
no
together.
matter how brilliant the surgeon, you're getting massive adhesions forming on your uterus. So and through the full depth of your uterus all the way to the surface. So
The abdominal wall can get stuck to the uterus too, as
Yes.
with adhesions.
Yep. So let's talk about your technique. So again, kind of go back to how you developed this and how is this different from surgery or other manual therapies? Like I know there's the Mercier therapy or just other visceral manipulation. What makes your technique? Obviously, it's more intense because I experienced it. It was more intense than anything I've ever ever experienced. It's like a
And the
whole week, 20 hours worth of therapy, not a 5 minute session. This was like hours, day after day after day. So explain how your technique is different and obviously superior to some other available techniques.
we wondered that, and the chief of staff of our hospital insisted that we conduct some clinical research. So I actually hired, besides a biostatistician, to do some research so we could look people in the eyes and say, this is what our data is.
Yeah.
It's real, what your success rates are, but also hired a PhD in histology, what happens at the cellular level of the body, and in disease modeling, how diseases start. And I said, Dr. Rice, what are we doing? Why are we opening these blocked fallopian tubes? I want to know what's doing it because
Yeah.
look people in the eye and I want to help more people, but I'd like to know. And she explained that when these crosslinks form in top of each other, these little adhesions they form, the strands themselves are very strong. They're like strands of a nylon rope. But between each one, there is a molecular chemical bond. And that bond is apparently susceptible to dissolving when we do our work. And we kind of go in slow and steady and just follow and follow. And it's like pulling out the run in a three-dimensional sweater in very slow motion. So that's what has been the theory. Would love to do it under laparoscopy, to actually film this under laparoscopy. But anybody we've approached about it said, well, why would I have a surgery if you're going to
Yeah,
I
yeah,
can
yeah, yeah.
afford it. So we have not done that, but that is what we gather is going on from the PhD that we hired. Quite
So
brilliant.
I'm not a physical therapist. I'm not trying to put words in your mouth, but just so
No,
listeners can understand, manually kind of, I don't want to say breaking, but you're slowly stretching and releasing those cross links. Is that
yeah,
what you're doing? And if I remember right, in different directions too. I seem to remember her kind of pulling in different angles, different directions very slowly.
yeah, again, all the organs and all the tissues we should be able to stretch them in any direction. So wherever we feel something feels stuck or it won't move in a certain direction, we'll apply a pressure with our hands and we'll hold that amount of pressure and that amount of stretch as long as it takes until we feel things start to soften and give way. And then we
Yes.
start picking up the slack. As things give way, we can take this will stretch a little more in this direction, so we'll follow that until we no longer feel any resistance to stretching the tissues or the
In a
organs.
way, it's almost feels like you might pull out the run in a sweater in different directions, only it's a three-dimensional sweater and it's in very slow motion and it's the body instead of a sweater.
So slow motion, so it's going to take time. So what does a typical treatment protocol look like? Like how have you guys arrived at this kind of, I think for the average person for initial treatment, the 20 hours?
This
Yeah.
that what happened was this radiologist in town got fascinated seeing all these blocked tubes that we were opening go by, and he called his father, who was a head researcher at NIH up in Bethesda, Maryland, and said, "Dad, you won't believe what these people are doing." So Dr. Wickman came down, moved to Gainesville to study us, and started publishing on us.
Wow. Wow.
And at that time, we were seeing a lot of local patients, but we'd see them 2 or 3 times a week for an hour, typical physical
Yeah,
therapy.
yeah.
We had people wanting to come to us from the Midwest or New York or wherever.
And other countries.
Yeah.
Dr. Wickman, we're treating both. How long does it take us to open blocked fallopian tubes, and does it make any difference if we do it quickly or spread out over 2 months? And he studied it and he did the biostatistics on it. And he said, Mr. Warren, it takes 16.2 hours on average for you to open blocked fallopian tubes. There is no statistical difference between whether or not you do this over the course of 4 or 5 days or whether you spread it over 2 months. I've compared all of your
Mm.
dozens of patients,
We looked at our
and this is
charts.
what your success rate is. I said, well, if we did 20 hours a week, if people make sure people can still walk afterwards, is that okay? And he said, yeah, that would take up both sides of it. So that's why we do a 20-hour protocol. If someone has had many major surgeries or severe trauma, like
Yeah.
we had some major traumas, they may, after 20 hours, decide, well, I think I'm going to go back there for another 5 or 6 hours. But
Hmm.
we don't push them. By the
Yep.
time they leave, people know whether they need
They have
to.
a sense of if
Yeah.
that's,
Yep.
they could
But
use more.
all the infidelities are basically 20 hours,
Sure.
20.
Well, I want to come back again since having another C-section. I feel like I need to tune up, or I
Uh,
just want to make sure
I,
I can loosen everything back up. Yeah.
you see, you kind of get a sense of what you need
Yeah.
then after
Yeah. Sure.
repeating it, because you know what we do. Yeah.
Are there any
Yeah.
conditions or situations where your technique is not appropriate or not effective? Is there anyone who's not a candidate?
Someone who has active cancer, we would not want to treat.
Sure.
Mm,
Sure.
That's the major.
At least not right there. I mean, if they have cancer at their knee and they're coming for abdominal, we might consider we're going to
Sure.
get clearance. If
Sure.
someone who has had surgery within the last 90 days, the surgeon from Harvard, she was there for 20 years. She kept sending us patients, and she said, she wrote a study on us, and she said, I want you to treat patients right after I do surgery because the adhesions form so quickly. And I talked to my therapist, and they said, no, we're waiting 90 days for
Okay.
everything to heal.
We want to
And
make sure everything's healed.
so we
Okay.
go through and clear, and we have people complete a medical history form and have a 17-page single page spaced document for any sort of questions or contraindications we'd have.
Sure. And then, of course, listeners are going to want to know how long do results typically last? Like, are the adhesions going to come back?
Well, we show patients things they can do using their own hands
I
to treat
remember that. Yeah. Yeah.
work on themselves. And as long as they do their homework, they should be good. Some do come back, when patients get lazy and stop doing their home program. So some people do come back for some more hours, maybe
Sure.
5, 6, or 7 more hours. But most of our patients we treat for the 20 hours and we never see them again.
Yeah.
And
Incredible.
especially the infertilities, because
Yeah.
really, when you think about it, Dr. Gray, the adhesions form due to infection, inflammation, surgery, or trauma. So if you or endometriosis, so if none of those things
Yep.
recur, there's no reason for them to come back.
Sure. Sure. So let's go back to female infertility. So for the listeners, let's list again kind of what causes of female infertility you have successfully treated. We've mentioned endometriosis.
Yep.
Sounds like
Block,
PCOS. Oh, go ahead.
yeah, block fallopian tubes.
One of the more and PCOS, one of the more fascinating ones we're seeing is high FSH,
Mm.
women whose FSH is over 10, so they are refused IVF.
Yeah, yeah.
It was a shock to us the first time I treated this woman. She came in with pelvic scarring, and I saw her on Thursday, but her cranial bones were not leveled, and so I thought, well, should I take the time? Well, I went ahead and leveled those out, and on Thursday and Friday as well. And we did not know her FSH was actually in a menopausal level. She went home, got pregnant the next month, had that child. We
Wow.
started I checked with the biostatistician, the chief of staff of the hospital. They said, get FSH levels before and after
Yes, yes.
patients. We did that with 16 patients. Looked back after 2 years. The first one is now pregnant again with her second child. And 6 of the 10 got pregnant before they got a chance to get their FSH levels checked. So, and in our larger 10-year study, we had forgotten how many, well over 100 patients, and
Mhm.
about 40% of them with high FSH would have been refused IVF, became pregnant after we treated. So that was a big surprise.
I can see the smile on your face, Larry. I mean, is it hard to just not get so giddy at all these testimonials you guys have had? I mean, just the miracles you've been able to like work into these patients' lives. I mean, infertility just makes me cry. It's just such a struggle and just the impact you guys have had. Yeah, thank
Yeah,
you for your work. But I imagine you still get excited about it. I can see it in your face as you talk about it, Larry.
it's very
I'm,
rewarding,
I'm
definitely
77.
rewarding.
I can't stop, you know. We want to go on. We explained, this doctor was explaining in a conference out in California, was explaining about what we did with the pituitary because of the FSH.
Mhm.
And the neurosurgeons next to him said, "Well, what about Parkinson's?" "What do you mean?" He said, "Well, where the pituitary is that far away from where the substantia nigra is. If they can relieve pressure on the pituitary, can they help Parkinson's by relieving pressure there?" Doing so,
Wow. Yeah.
do that
No,
before
no.
I shuffle off this mortal coil.
Well, my next question was going to be, can you explain how your work affects hormonal function in reproductively older women? But you kind of just answered that. I mean, in the FSH case. So hormone levels, it sounds like improve after therapy.
Yeah.
Um, and I don't know if you
And
want to add to that, but yeah.
just the when it started happening, I talked to some of the researchers at the University of Florida, the medical school in women's health, and they said, "Well, Larry, the nice thing is you don't have to inject FSH or you don't have to inject hormones, but more than that, when one hormone improves, the others
They all
tend to
improve.
improve."
Sure.
So they got really excited about that. So
I can't help but think that's also because what we haven't mentioned yet, but I seem to remember is you work on patients head to toe. Like what you're saying to listeners is you're doing cranial sacral work. You're
Right.
not just working on the pelvis. And
Yeah.
actually you do internal
Oh,
work as well, internal, external, head to toe. I mean, this is a full body workover if you want to expand on that a little bit. Yeah.
we definitely treat the whole body because if you look at the body and the fascia, which is our connective tissue, it's a three-dimensional weave of collagen that runs from head to toe and front to back. So it's all connected. So you can't just treat the pelvis and not treat the head, especially if there are hormonal issues going on. You know, we definitely would want to get in there and do some cranial work to free things up, to relieve any excess pressures on on the pituitary gland, for example.
Sure.
one thing, just along that line, one of the
Yeah.
things we do, and incidentally, we don't, as you know, we don't push anybody into internal work.
Yeah.
We want everybody comfortable, but when
It
we
is
were
very helpful for a lot of conditions.
Yeah. Yeah.
treating a severe headache in a gentleman who had fallen at a construction site. We couldn't get rid of. We got everything else right. His torticollis went down. He got it back to work, but
Mhm.
just had terrible headaches. And finally, we were driving home. It was just the two of us way back then. I said, "Do you think maybe when he fell, it pushed his tailbone forward and it kind of pulled the entire dura down, and that's
Yeah.
reason there?" And yeah, that makes sense. "Well, what do you think we should do?" So we decided we would ask him if he wanted to be treated internally. We'd bring that coccyx down while the other one's traction in his head. It sounds kind of crazy. Maybe we should call his doctor first and make sure that's okay. So we called the doctor as the head of workers' conference, state of Florida, never got back in touch with us. Patient comes in, we suggested that we treated him. He on a Thursday morning, and went on to the rest of our patients. Unbeknownst to us, he went to his doctor Monday morning and told him, and his doctor said, "They did what?" He said, "Yeah, doc, sure found out two things right away. Now you gotta understand, this was a while back, an old Southern kid. And what'd you find out?" The doctor said, "Well, one, I ain't gay." So the doctor's trying to keep it together. He said, "What else did you find? Found out what a good doc you are to know to send me to the place that not only got me back to work when nobody else could, but also got rid of my headache. I ain't had one since they done that. I've had them every day for 3.5 years, about 8 or 9 headaches,
Wow.
level
Wow.
headache."
Pretty dramatic
So
decrease.
that started showing us the connection between the coccyx, the dura, all the way up to the cranial base and into the fascias that surround everything in the head.
Sure.
For our severe headaches, we will suggest that if we think it's appropriate,
Yeah. Yeah.
and
Yeah.
in some of the hormonal
Yeah, I
cases.
mean, falling on their butt is a very common thing.
Yeah.
People slip and fall.
Of course, with
Yeah.
the we can do that vaginally, but
Yeah, yeah. I mean, I had a severe snowboarding accident. I fell very hard on my tailbone. It's I mean,
Oh,
permanently deformed, right? So,
Mhm. Right.
but also, so I'm
Um,
just a lot of people I think forget they had that injury 15 years ago or whatnot,
that-
right? And suddenly that showed back up in my head when I was trying to get pregnant, like, whoa, could that have impacted my, again, limiting my mobility, my uterine mobility or whatnot?
that's
Start to
it.
think of all these things. Yep. But then also, of course, with endometriosis, the rectum can be impacted as well. That's why a lot of patients get pain with bowel movements and whatnot. So sometimes internal work is just really important. And obviously, that's up to the patient if they want to receive or not, but that's part of treating the whole body. So, yeah.
exactly.
Again, what sets you guys apart? Yeah. I want to mention some statistics here because I think you sent me, Larry, that you guys have had over 2,000 female infertility reversals. Is that right? 2,000
That's about right. We passed a
published. Yeah.
thousand
Yeah.
about 10 years ago, so we're at
Yeah.
right at about 2,000.
That's amazing. You've already shared some very memorable success stories. Are there any others, maybe before we move on to some, move on past infertility? Are there any other infertility um,
So let's
cases
talk
you want to
first
share?
IVF story. So
Yeah.
we've just started in this this woman comes to us and she says, "Well, I'm already scheduled for IVF. I've had two before and they both failed. Do you think you can help?" And it's, I don't know, we'll
It's worth a shot. Yeah.
Give it our best
give it a
shot. Yeah.
shot. So
Yep.
so I'm treating her. It happened. I was treating her internal, and I said, "That's what's that?" She says, "Well, it's your cervix is really curled up and kind of attached to your vaginal wall."
Like
Oh, yes, she says, "I can tell
posterior.
you about that." What do you mean? She says, "Well, every time my doctor, my RA, reproductive doctor, goes to put the catheter in to
Yeah.
insert the embryo, he's really sweating because he can't get it into the cervix
Can't
and
feed it
all.
in. Yeah. Yeah.
Yeah, can you think you can do anything about that?" And I said, "I don't know." And so we worked that for a few sessions. She comes back after a month after her IVF. I said, "How did it go?" She said, "Well, number one, I'm pregnant." I said, "That's great." She said, "But I got to tell you about it. It was really wild." I said, "What do you mean?" She said, "Well, because the doctor comes into the room, he's always been afraid the embryo is going to die in the room temperature of the room while
Well,
he's
he's
trying
trying to
to."
get this catheter in. Yeah.
Yeah.
Right.
And he gets the catheter and he goes to put it in, it goes right in. She said, "Larry, he immediately grabbed the chart and looked at it to make sure I
Sure, he
was
had
the
the right patient.
Right
person."
patient.
And afterwards, he said it was the easiest transfer he had ever done. So our statistician did run all the numbers for treating before IVF. So if we don't get pregnant with us, our success rates were improved in every single age group for women before IVF when they were having therapy before IVF. And for women over 40, the rates were 5 to 9 times the SART national averages. So
Wow. Wow.
it
I
helps.
mean, it sounds like regardless of where a patient is on their infertility journey, the beginning, the end, they're already pursuing IVF, like your therapy can help again increase success rates. So,
Yeah. Yeah.
yep.
Yeah.
Okay.
Definitely.
Beyond infertility, we've kind of already mentioned this too, but I still want to ask some of the questions. Can
Sure.
you reduce pain with intercourse, period pain, and increase sexual function?
Yeah, another cute story is I hope these stories are okay, but this woman called Belinda up and said, "I'm 45 and something really unusual happened." Belinda says, "What happened?" She said, "Well, I'm having
After we treated her.
after
Yeah,
we
yeah, yeah,
treat
yeah, yeah, yeah. I bet I know what you're going to say. Okay, but go
I'm
ahead.
having orgasms like I've never had before." Belinda goes, "Is that okay?" Being
Because I can't take
appropriate.
back what I did.
Yeah, right.
No, these are real toe curlers, she says there. So this happened several times, and Belinda asked me what to do about it. And I said, "Look, don't even talk about it. We're already the weird practice in town. We're opening tubes. But we're at dinner with Dr. King, and he said, "That's really important." "What do you mean?" He said, "As a gynecologist, all we can do for intercourse pain is to provide analgesics, pain relief, or a gel to
A
anesthetize a
numbing,
person,
numbing gel.
numbing agent. If
Sounds
those don't
horrible.
send
Hey,
them to a
drink a
psychiatrist
glass of wine.
or,
Yeah.
drink a glass of wine or see a psychologist or psychiatrist." So he said, "We have to do a study on this." And I said, "We do?" He said, "Yeah, yeah, we do." So we did, presented at the American Society for Reproductive Medicine. We were as surprised to find that the audience, 90% of the audience were psychiatrists and psychologists because they thought that's where intercourse pain was for women.
In the head, right?
As they were surprised to find that it's actually
It's a real
where
physical
you're
thing.
feeling it.
Mm-hmm.
So our success rate for general population and for endometriosis, women with endo, is in the 96 percentiles. That's the highest
Decreasing pain with
for
intercourse.
decreasing pain with intercourse.
That
The
is
low,
amazing. That is
the
quality,
lowest,
extreme quality of life improvement. Yeah, that is.
yeah, because
Yes.
people, I mean, they want to have pleasure.
Yeah,
They don't
yeah.
want to lose their spouse or their
Yes.
partner. And the lowest number was orgasms increased for 56%, and the lubrication, desire, and arousal
Yeah.
were under measurable and
Yeah.
domains, and they're all in the 78%, 76,
Wow.
78% improvement. So it's like taking your body back in time to an earlier time before these things
All
laid
these
down.
traumas.
Yes, yes.
You know,
Stinking
have
adhesions.
things together or
Yeah, I
covered
know.
in it.
Stinking adhesions,
Yeah.
they're a big problem.
Yeah, that's what I'm going to name this episode, Unstunk. Or not stuck, Unstuck.
Unstuck.
Stinking
Right.
adhesion.
There you go.
Let's move beyond infertility to other conditions you treat. So I also had SIBO, and so that was something I was looking forward to also having you guys, help treat on me. So let's talk about maybe the connection between adhesions and small intestinal bacterial overgrowth, but also small bowel obstruction. So maybe let's go GI for a while. Can you explain how your therapy can help with those conditions?
Go ahead.
Okay, I'll take it. So, well, with SIBO, I get a call one day from this Dr. Seebecker. I didn't know him. No, it was
Sandberg
SSL,
Lewis.
Dr. Sandberg Lewis. What are you doing with our patients? I said, what do you mean? I'm a little worried. And he said, well, this patient has SIBO, and every time we would give her meds, the SIBO, the meds would work for 2 or 3 days and then they'd stop. And she's lost so much weight because of the bacteria eating her food. She's normally 135 pounds. She's down to 86 pounds. She's in a wheelchair. She's going to die. She
Malnourished. Yeah.
saw one of your therapists, and now the medications work, and she's back. She's out of a wheelchair.
Back to normal.
And saved her life. What are you doing? I said, well, that's good, but
What is SIBO?
What's SIBO?
Know what it was then.
So he flew here from Oregon, where he was the director of gastroenterology at the Naturopathic College there in Portland, and met with the PhD that I talked about the other day, and the chief of staff of the hospital, and me. I was the small mental person in the room, and we realized that because we are clearing adhesions within areas, like within an area as small as a fallopian tube that's designed to carry a single cell, we're also clearing adhesions in the bowel.
That ileocecal valve that connects the small intestine to the large intestine, right, can get stuck, just for the listeners. So it's not necessarily opening when it's supposed to open or close when it's supposed to close. So the bacteria from the colon can then flow upstream into the small intestine. So it's, very important that valve, I'm sorry to cut you off, Larry, but
no, that's fine.
Isn't restricted. Yeah, yes.
Bacteria can get out of the body.
Yes.
So we figured out so we created a protocol so that when people have SIBO and really chronic SIBO, and they really need to get rid of it, they've had it for years, we'll have them start their rifaximin or their nutraceutical, whatever it is, before they come. Then we treat, and as we treat, and the chemicals are killing the SIBO bacteria. We're opening things up so that they can be eliminated from the body, because in the case I stated, there was just no way to, once they were treated, the SIBO was treated, there was no way to get it out of the body. And so we treat it up. And then this surgeon from this Harvard surgeon was sending us a lot of patients that she just said, I just don't want to operate on them anymore. I can't see through there. They're so adhered. I might have an enterotomy cut through an organ I don't want. She was sending us patients and did a study on clearing small bowel obstruction. Small intestinal surgery, generally from small bowel obstruction, is the second most common emergency surgery in the U.S. According to JAMA, and adhesion surgery is the fifth most common emergency surgery. So you can see the importance of decreasing adhesions
Mm-hmm.
with these rather than
Surgery.
with
Mm-hmm.
surgery.
Wow. Wow. I was going to say something about SIBO, just real quick, going back to just for the
Go ahead.
listeners, like a lot of patients with SIBO have been, again, treated with antimicrobials, whether they're drugs or, nutraceutical like supplement products. But if we're
Mhm.
never addressing structure, then we're not truly getting to the root cause. And there are lots of root causes of SIBO. Not every patient with SIBO has adhesions, to be clear, but some of them could have adhesions contributing to them not getting well. Just wanted to
Right.
clear that up.
But
Oh, what would you say to someone whose doctors told them their only option is surgery or IVF? I'm coming back around to infertility here, but what would you say to them? Or what do
Prove,
you say to them every day?
prove them wrong.
you have to go with your heart,
Yeah, prove
but
them wrong.
generally you try to start it. The basic tenet of medicine is above all do no
Do no
harm.
harm. Right.
So if you can start with something that is non-surgical, that's
Conservative.
Yes.
not going to hurt you, that if you have to have an IVF, it's going to improve your success rate with that. But why not do that rather than something that has been shown to cause adhesions whenever it's performed, virtually every time? So that's what I would say.
From your 38 years of experience, what's the most misunderstood thing about adhesions and fertility? Maybe you've already mentioned it in the show, but
I think we pretty much covered all of that. I mean, we've had doctors say, well, adhesions can't cause pain, which is
Well, that's baloney.
yeah, yeah, yeah.
you got 18,000 pound a square inch rope or curtain pulling on things,
Squeezing.
you're trying to stand up straight and it's pulling you forward. And if you find you're being bent forward all the time, a lot of times it's and you've had surgeries, it's because the adhesions, because it's uncomfortable to stand up straight because of the
You're gonna have back
pulling.
pain because you're pulled over.
So that's one of the ones that adhesions don't cause pain. Adhesions have to be treated surgically, it's just not true.
False. Yeah.
Yeah.
So many surgeons send us their patients that are like the one I described, where the doctor says, "I just don't want to do
Yeah.
surgery on you
Yep.
anymore."
You're
Yeah.
that bad. Yeah.
Yeah.
Belinda, is there anything that listeners can do if they're listening and they feel like, oh my gosh, I know I have adhesions, I've had SIBO. Are there, maybe this is not an appropriate question, but are there any exercises or anything that they could do at home? Obviously, they need to connect with you and we'll get to that, but is there anything they could do? Any basic stretches? Any?
Oh gosh, that's hard to say.
Yeah,
Any position that they can get into where they feel the stretch and hold the stretch. That's the thing. Most people when they stretch, they don't hold the stretch long enough to create lasting change.
sure,
So just hold the stretches longer. They'll get better results.
sure, sure.
They'll be more helpful.
And then, of course, I want to come back to your story. So we opened with kind of this devastating news. You had cancer, you went through aggressive treatment. You guys researched obviously
Mhm.
this therapy that you've created. So are you comfortable sharing where your health is now? Where, were you able to heal? Do you have chronic pain? Or how are you? Yeah.
Well, I'm 35 years older. So there's that. But I'm good. I'm good. Um, I ended up having to have a colostomy.
Sure,
So
sure.
my gut issues are different, but
Yep, yep.
The problem with Belinda was that with the radiation therapy, so much of the
yeah,
tissue
just
was
damaged a lot.
damaged. It was like friable. You touch it and it falls apart. So we couldn't do that. We couldn't treat that part of it. But the
Sure,
adhesion,
sure.
sure.
But you're the reason why this therapy was created. So is there is there anything else you guys want to show before you want to share before we wrap up the show? Anything we haven't covered?
No, I think just following your heart, listen to your heart, use your head, ask a lot of questions. If you want to complete a medical history form, because as you mentioned, Dr. Gray, we look back from your snowboarding accident 15 years
Yeah.
ago. We look back over patient's
We
history.
look at lifetime history of trauma.
Yep.
We'll review all of that. There's no charge for any of that, and just see, if you're appropriate or you're not. We'll have a conversation,
Yep.
whatever. So that may be a nice benefit. We do have a few gifts on the website. I did one book of 80 remarkable infertility successes, narrated and written by patients. So that's available at the website. I don't know. Do you have
So
anything else?
tell us the website. So tell us where listeners can find you. Yeah.
Yeah, it's www.clearpassage.com.
So it's just Clear Passage.
Clear Passage.
And where are your locations? I went to St. Louis because I'm in Iowa, so that was closest for me. But where are your locations? Yeah.
Our home office is in Gainesville, Florida, North Central Florida. And then we have one in Manhattan, one in London, one in St. Louis, Reno,
in Dallas.
oh, in Dallas, right.
Yeah. Yep. So I imagine a lot of patients fly in for a week, get their therapy, and then
That's
fly
it.
home. Yeah.
That's
We
exactly
fly
right.
in on Saturday. They're
Yep.
treated Monday through Friday, 2 hours in the morning, 2 hours in the afternoon for the 20 hours, and then they leave usually on Saturday.
Yep. Yep.
We suggest trying to get home on Friday. It's just too much after treatment.
Yep. Yep. Sure. Well, thank you so much for coming on the show today, being here, sharing your incredible knowledge and experience. And most importantly, just thank you for the work that you do. You've literally changed the trajectory of the lives of thousands of patients, especially women, right, and families around the world. So what you've created over the past 40 years is truly remarkable. I hope you know that. Non-surgical solution that helps people avoid invasive procedures, reduce pain, restore function naturally. So for anyone listening who's dealing with infertility, chronic pain, bowel obstruction, SIBO, right? Any of the conditions we discussed today, I cannot recommend Clear Passage highly enough. So visit clearpassage.com. And lastly, what is your top longevity tip?
We like stretching. We like staying active. Kind of like Belinda said, if you feel, remember when you were a kid and you used to stretch like this in the bed and you just weren't really thinking about what you look like?
You wake
Do
up slowly, you
yeah,
stretch.
right.
Do
And
that
let them be long stretches. So you can do
like cats.
yeah. And take care of yourself. Listen to your body.
Drink lots of water.
And if you're having problems, call somebody. Find a therapist that knows how to treat adhesions if you can find someone, or give us a call and send us some history and we'll go over and educate you, and make your own decisions. So, but there's one life to live. Better get the best out of it.
Heck yeah. Perfect. Well, thank you again both for being here and pioneering this work. You're changing lives every single day and creating families. So this was a very special episode. I look forward to sharing it with my audience. Thanks for coming on the show.
Thanks
And,
for having
and
us.
thank you and congratulations on your new book on infertility.
Thank you.
Okay.
Bye-bye.
Now I can't.